Okay. All right. Good morning, good afternoon, good evening for people joining online. Welcome to our monthly lecture series on high-field MRI at the Kirby Center at Kennedy Krieger Institute and the Johns Hopkins School of Medicine. So this month, we are delighted to have Dr. Erik Middlebrooks from Mayo Clinic as our honor speaker. So I just do a very quick introduction. Dr. Middlebrooks got his MD from University of Alabama, and then he did his residency and a fellowship in University of Florida. He's currently a full professor and a consultant in the Department of Radiology and Neurosurgery in Mayo Clinic in Florida. And he's also been the director of the fellowship program in neuroradiology. Erik is known internationally as an internationally recognized leader in functional neuroimaging, especially I think epilepsy and neurodegenerative diseases and lots of other work. And he's been leading the 7T program in Mayo Clinic. Has been doing lots of nice work on high-field MRI, MR spectroscopy, and application in different diseases. I myself, personally, I met Erik first time about 3 years ago at the RSMRM high-field workshop in Lisbon. I remember I was literally amazed when he told me they do more than 1,000 clinical 7T cases, right, on their 7T system. At the time when in most institutes, the 7T remains a research toy, but they are putting through quite significant clinical volume through the 7T system, which is amazing. So I guess he'll tell us more today during his talk, which is titled Ultra-High-Field MRI in Clinical Practice, Where We Are and Where We're Going. So I'm very much looking forward to your talk, Erik. Thank you so much.
Thank you, everyone, and thank you for the introduction. The purpose of my talk really is just to kind of give my experience and how we've applied 7T to the clinical practice, and just show some examples of where we think this has made a difference and some potential future applications. The first question is, why use 7T? And obviously, bold imaging and MR spectroscopy were really large drivers of the development of the 7T platform. And we know that SNR increases about linearly with the B0 field, but the bold SNR increases much greater. And this is just an example from the Martinos group in Boston, showing kind of layer by layer specific visual activation. And we'll come back to why this matters a little bit later, but you can see one thing to notice is when you look through individual layers, you can see as you get near the peel surface that these images become a little less clear of what the true activation pattern is. And this will be important a little bit later on. So the question is, spectroscopy and fMRI are really just a very small fraction of clinical neuroimaging. So the question is, what else could we use 7T for? And I think it's easy to hypothesize where 7T could be advantageous, and but there's a lot of challenges to it. And I think some of the common myths that I commonly hear is that people think you can just do things really fast because the SNR is so much higher. And that's not necessarily true. And then also that, anything we do, we can just do these like super high resolution scans. And so just to give you some background on the 7T, the FDA approval for this, this is a picture of our system, is the Terra. And it is a smaller bore scanner, 60 centimeter bore size. It's a very heavy scanner and takes up a lot of room, not only the scanner size, but also the equipment room. So it ends up taking up 2 or 3 times as much space as a typical 3T scanner. And so this is important when considering how you site these, where they can be constructed. And we were just talking about, the system here is, it seems like with every installation I visit, there is some kind of like catch of having to come up with some marvel of engineering to make these systems fit into existing spaces. The other FDA-approved system is the GE Signa, which is received FDA approval after the Siemens system. And there's a picture of it. And just some background on the FDA-approved uses. It's currently only approved for brain and knee imaging. And we'll talk about why that is in just a moment. And then we have very rigid safety standards for metal and implants. And I've seen this implemented in a variety of ways, from some places that if you have any implant, you're not scanned, period. We try to be a little more selective, and we do scan things that we feel really are no significant risk at 7T. But the problem is there's no actual safety guidelines for these implants at 7T, and there probably will not be any for the foreseeable future. So this does present some challenges with imaging clinical populations, as we often have patients that have a variety of implants, many of which would really have no theoretical added safety risk at 7T, but we want to try to not exclude those patients. There's also an absolute weight requirement of over 30 kilograms. So this somewhat limits its use in pediatrics currently. This is related to the SAR. And so we've talked to the manufacturers about this. There's obviously a lot of interest in imaging pediatrics, and they don't foresee this changing anytime really soon. And then a relative weight limit of, if we use about 110 kilos just due to the bore size. Here are just some of the common imaging coils that are used on different 7T systems. One of the important things to note about the system is there's no table body transmit coil. All the coils are local transmit receive coils. And so this is the geometry of most of the head coils, where we have the receive elements with this transmit sleeve that slides down over the top of it. And usually the system standards are this Nova single transmit 32 receive coil. And then this coil doesn't have great coverage, particularly in the Z-axis. And so we actually use this other coil as a Nova 8-channel transmit 32 receive. And so in our clinical scans, we don't do a lot of true parallel transmission, but this coil has much better geometry, and we get better images even using it as simulating a single transmit coil. There's also a single transmit 28 receive knee coil by QED, and then there are separately tuned head coils for non-hydrogen nuclei. So just for people not familiar with the 7T, some of the things to consider when we talk about where 7T is advantageous is you have to remember that the SAR is much higher at 7T. So this can necessitate having longer scan times, the prolonged T1 relaxation. So some things that you think might be highly advantageous at 7T are not quite as advantageous as you might think. And then we also have to deal with kind of sequence-specific issues, such as spin echo sequences that have really high SAR. And so depending on the applications too, we may have to use higher bandwidths to reduce distortions and susceptibility effects. So this also can lower your SNR. And then some newer technology like parallel transmit can greatly increase scan time depending on its implementation. So ultimately, all is not positive. So obviously, at a higher B0 field, we get greater susceptibility effects, more distortions, more signal loss. We also have to deal with this B1 transmit inhomogeneity, and I'll talk about this in a little more detail. And then obviously the SAR scales quadratically with a B0, so this becomes a much bigger issue at 7T. And then what we have found in the clinical implementation, one of the biggest barriers from scan to scan is the increased sensitivity to motion artifacts. And this is really multifactorial. It's partly due to our own doing, because we generally kind of push the limits of acceleration using high resolution, high temporal resolution. And so we kind of somewhat set ourselves up to be sensitive to these motion artifacts, but also the longer TRs, the B0 shimming as patients move, all of these things really can kind of add up. And so I think this has really been one of the more problematic things that has to be addressed at 7T. So I'm not going to talk much about the physics, but I just wanted to mention this because this is one of the biggest current barriers, I think, to 7T being routinely used is the B1 transmitted homogeneity. And this is just showing the just a B1 map from a subject. And you can see centrally we have a much higher B1 than predicted, and this kind of dissipates out to the edges. And you see in like the posterior fossa where it's actually much lower than predicted. And so this really, I think, is one of the bigger challenges to implementing 7T. And the reason for this is due to the wavelength that we use at 7T. So at 3T and 1.5T, these wavelengths are generally larger than most anatomy we would image, whereas at 7T, we have about 11 centimeter wavelength. So this is smaller than the human head. And so this, what happens is we now get the effects of these waves interacting with each other. And so this produces inhomogeneity in the B1 field. And it leads to something like this, where you have areas where the contrast is what you expect, and then areas where it's higher, lower, and it can be a very tricky problem to solve. Depending on the sequence, there's kind of varying susceptibility to this artifact. Things that are flip angle dependent, like space, are pretty heavily affected, as you can see here. You can see this artifact here. So this is kind of how our system was delivered, which obviously this is not ideal. But we've really been able to compensate for a lot of these in most of our patients. And the way we do that is primarily through sequence optimization, and then we use passive B1 shimming mostly, which would be like dielectric pads. There are also ways of doing intensity normalization. A lot of the ones that are applied at 3T are not applicable to 7T, like the normalize function that you commonly use with like 3T phased array coils. And there are reasons that that's not applicable in 7T, but there are some that have been adapted to 7T. Our experience is that it doesn't work well. It may make the signal intensity look a little more uniform, but it comes at an SNR penalty. So it's really just more of a cosmetic fix than it is a true fix. There are some new deep learning approaches to the intensity normalization that I think are promising, but we don't routinely use this. And then ultimately, active B1 shimming or like parallel transmission, I think is probably the ultimate solution, but is not quite there. It is also not FDA approved. So here, just some. This one's not playing. Just some examples of some of the routine images. So here's T2 space. And so again, this is a sequence that's a little bit more susceptible to these B1 inhomogeneities, but with dielectric pads and the sequence optimization, I think we do a pretty good job. Here's flare is we were talking about this last night. Is I think one thing that's a little more challenging at 7T, but again, we can get pretty good quality imaging. Double inversion recovery is another commonly used sequence that suffers from pretty low SNR because of the two inversions. And so this is something I think that's advantageous at 7T. So let's just talk about some of the clinical applications. So one of the things that we do a lot of is multiple sclerosis. And because of the SNR improvements, contrast, and then the added T2 star effect really offers a lot of advantages to imaging MS patients. And some of the MS consortiums have actually suggested this should be the standard of care, but obviously, the limited access, this isn't feasible. And so some of the important findings are the central vein sign, the phase rim sign, and then cortical lesions. So the central vein sign is something that's been known about for many years in MS patients, that they have this predilection for these veins. And 7T is highly advantageous for detecting these. One study they looked at found less than half of lesions on 3T had a detectable central vein versus almost 90% at 7T. And if you use a cutoff of over 40% of lesions having a central vein sign on 7T, it was 100% specific. And it was actually, as an independent variable, was more predictive of MS than the current gold standard of the McDonald criteria. And so we see this example here. You can just see all these lesions. They all have this vein right in the middle of them. And so often, we see these lesions that are more peripheral, have very, very tiny veins in them, very difficult to detect at lower field strengths. Here's just a patient who had just a solitary lesion that obviously doesn't meet any criteria for MS, but we see they have this central vein sign and ultimately was determined to have MS. Here's just the same patient showing 7T versus the 3T. And so even really far out, these tiny, tiny lesions, we can see these central veins. Here was a patient who was referred to us with an outside suspicion of MS, and you can see that all of these lesions have these eccentric vessels associated with them, and this patient actually just had migraines with auras. This was another patient. I thought this was interesting. She had this hereditary leukodystrophy that we ultimately discovered, but she first was given this diagnosis of MS. And when we scanned her, it was clear she did not have MS, which ultimately led to her diagnosis. But I thought this case was interesting because you would think statistically, you have a bunch of these lesions, some of them are going to have a central vein, but it's really remarkable how few of them in non-MS lesions actually have central veins. And if you compare this with the MS, where you see almost every lesion has a central vein versus this one, like you can't find a single lesion that has a central vein. So it's really, I think, a powerful biomarker. Another thing that's been described is this phase REM sign, and this is thought to be a marker of persistent inflammation. And the idea here is that initially in the inflammatory phase of these lesions, where you have the cytokine release, all this blood-brain barrier breakdown, you have enhancement, that can all reverse, but you still have this persistent macrophage activity and inflammatory change. And so these are thought to represent those microglia, the iron within those microglia cells. And so the idea here is that this phase REM should go away early in the course of the lesion to have a good outcome. If it persists, then these have worse outcomes. And so here's an example from the literature just showing over time that you initially have this enhancing lesion and you have this phase REM that quickly goes away. And then this lesion becomes pretty small and non-cavitary. And then this lesion, you see this phase REM sign that even after the enhancement is gone, this phase REM persists. This lesion obviously has a worse outcome, that larger, cavitated. And so, this really hasn't made it into any kind of treatment recommendations or guidelines yet, but I think ultimately it may prove as some guidance in modifying treatment in some patients. The next thing to talk about are cortical lesions, and these are important because even though we really think of MS as like a white matter disease, it does affect gray matter. And in particular, we see some patients that have lots of cortical lesions. Other patients have really bad white matter disease and no cortical lesions. So I think it's not entirely understood why some patients have a predilection to get these cortical lesions, but they're important because they may better predict their morbidity and cognitive change than the white matter disease. 7T is in one study, so they found that it detects over 50% more cortical lesions than 3T, but I think this is also dependent on the lesion type. And here's just kind of the classification of those. So you see on the top, these leukocortical type 1 lesions that involve the cortex and subcortical white matter. These, we see these on 3T, so I don't think this is really something unique to 7T. But as you move to these type 2 and type 3, the purely intracortical and the subpial lesions, we see that those become very hard to detect at 3T. I think if you read a lot of MS cases on 3T, 1.5T, you probably would say like you really rarely see these. So we see them much more commonly at 7T. So here was an example. This patient has this lesion here in the cortex. We use this gray matter null sequence here. You can see the lesion here. This was an outside MRI that was actually done after the 7T. And so, I would have never called that. Here's another case. So again, the 3T here, it's very difficult to see anything. On the 7T, we see this lesion here. This is something that we couldn't find described anywhere in the path or imaging literature, but we frequently see these lesions that are on kind of opposite sides of the sulcus. And so we see this way more than you would expect to just occur by chance. So there's probably some pathophysiology, some kind of draining vessel or something that explains the link of these lesions across the sulcus. What we also find, though, is we have a large MS clinic, an autoimmune neurology clinic. So we see a lot of patients get sent to us with some outside diagnosis or suspicion of MS. So we found that this is a powerful tool for refining that diagnosis. So we see many mimics. And so this was just showing one of these cases of this young woman who had these very convincing symptoms that she kept having these left-sided sensory motor symptoms, weakness, paresthesias, imbalance. She'd go to the ER, she'd get an MRI, was essentially called normal. She had a few of these little white matter lesions that were kind of nonspecific, but they thought based on her clinical history that it sounded like she probably had MS. So they sent for a referral. And on the 7T, we actually see all these tiny, tiny little cortical like microinfarcts and encephalomalacia that you don't see on the 3T scan. And so they're all clustered along her right sensory motor cortex. The more you look, the more you see. So it turns out that we found that she actually has this MTHFR mutation, which is a hypercoagulable state and a known risk factor for stroke. So we were able to kind of refine her diagnosis to the correct diagnosis in someone who does not actually have MS. Here was another patient who was a young woman who had presented with personality change and some cognitive complaints. She had a mother with a history of early onset dementia, and that was all that was really known. And she had this MRI, has a few of these white matter lesions, and was sent to us for a second opinion. And we see, compared to our 3T scan, we see all of these little microcalcifications along the cingulate that you don't really see on the 3T scan. And this is known that these lesions are not well seen on SWI, but these are these so-called stair-step calcifications that you see here along the cingulum. And this is fairly pathognomonic of this disorder that used to be called HDLS, but is now known as CSF1R-related leukoencephalopathy. So this is a hereditary disorder with variable phenotypes and penetrance, and so we were able to refine her diagnosis. One of the earliest things that we started using the 7T for was ALS. We have a very large ALS clinic, and these patients can be very difficult to diagnose early on. And so when we were first kind of getting going with the 7T, before we had opened it up for patients, our neurologist who does our ALS clinic called and was like, hey, I have this patient, very, very unusual case. And I was wondering if maybe I could just send her down and you all scan her, just to kind of test on the 7T. And it was like a slam dunk case. And ever since then, he orders 7T on every one of his patients. And we found this to be very helpful. And so this idea of this motor band sign on gradient images has been documented at lower field strengths, and it's related to iron accumulation in the microglia. But unfortunately, this sign is not really specific to ALS, and you can see it in just older age and a lot of other neurologic disorders. And so if you talk about this sign to a neuroradiologist, they'll tell you, you will not infrequently open up a case. They have this striking motor iron sign, and the patient has no symptoms of ALS. And so we're suspicious that maybe 7T could improve our diagnosis on this. And the reason is because ALS actually has a very unique pattern of iron deposition that begins in the middle layers of the cortex. It somewhat involves the inner layers, but it spares the outer layers of the cortex. And this localization is where the cell bodies of the corticospinal and callosal neurons exist. And so this unique pattern is what we thought that you might be able to actually image on 7T with the added spatial resolution. And so here's an example of this patient with ALS. And again, you see this striking iron deposition within the middle layers of the cortex. There's some involvement of the inner layers and then sparing of the outer layers. And you can see that again on the phase images with this striking involvement of the middle layers of the cortex. And here's just showing a patient here with ALS. You see the middle layers, the inner layers, and then outer layers, whereas this patient who was, I don't remember what they were imaged for, but the older patient with no symptoms of ALS, you can see has this kind of full thickness iron deposition through the cortex. So the next thing I'll talk about is epilepsy, and this is really the reigning champion of clinical 7T. I think it's where we kind of have the most evidence of 7T making a big impact on patient outcomes. And it's important because post-op seizure freedom is almost 3 times as high in patients who have a positive MRI. So the MRI alone is one of the most single predictive features of patients with epilepsy. So it's obviously very important that we maximize our yield of detecting lesions in these patients. But unfortunately, we still see a majority of patients are MRI negative with conventional MR. 7T, though, is much better at detecting these lesions, particularly things like focal cortical dysplasias that are very difficult to detect at lower field strengths. And this meta-analysis found that almost 2/3 of patients had a lesion on 7T compared to only 22% at 3T. These studies, it will say, they're a little bit biased because most centers have only referred patients to 7T who had focal onset. So were patients who were most likely to have a lesion, but still these are the patients we're most likely to cure. So it makes a big difference. And then a study out of UCSF found that 2/3 of patients who had bilateral polymicrogyria on 7T had been considered unilateral at 3T. So it also gives you a better idea of the full scope of disease. Importantly, though, that the confidence in the 7T images is reflected in the inter-rater agreement, which you see here is much, much higher at 7T compared to 3T. Here are just a few examples. So this young man, he had epilepsy since childhood, had been worked up at several major children's hospitals, had been considered MRI negative, PET negative focal epilepsy. And this on a 7T scan, you can see this is, we call this EDGE. This is something we actually developed this at 3T, and then we're able to port it to 7T. And you can see this junctional band here, this thickening. You can see it in the MP2 range, and then if you have an arrow here looking back, you can see there's maybe some blurring here, but this kind of volume averaging effect is very typical at 3T. So a lot of times these just kind of get dismissed as kind of a volume averaging artifact. So this relates back to that confidence in detecting these at 7T. So here, just again, you see the lesion in the coronal plane. This patient had actually at some point in their prior workup had an MEG. And you can see you couldn't make a better correspondence if you tried. And even knowing this, they could not find this lesion having an arrow drawing to it. So he actually was determined to have this DEPDC5 mutation, which is associated with these basal sulcus dysplasias. We put a laser catheter in there, ablated that. He's been seizure-free for over 1.5 years now. So that's the impact 7T can have. Here are just another few examples. This patient, again, was considered MRI negative, had very focal onset, had a PET where you see this focal hypometabolism in the frontal pole. And then so we decided to do a 7T, and you can see this dysplasia here. This patient ultimately went on for a resection. So you can see very, very difficult to see on the other scans. This is just showing why I think this EDGE sequence is valuable. Just the contrast to noise is much higher than this. DIR is often quoted as better detecting these FCD lesions, but you can see here like it's very hard to see on the DIR. The other thing that we find valuable for these epilepsy patients is evaluating the hippocampus. So obviously with 7T, we can do much higher in-plane resolution, get better internal architecture of the hippocampus. And then we can also use much thinner slices. This is a little bit challenging because of the SAR. This is a turbospin echo sequence. So it requires some careful optimization to be able to get the whole hippocampus within the field of view. And so the assessment of this internal architecture is really important in epilepsy because while we commonly think of patients with mesial temporal sclerosis as having this just like completely destroyed hippocampus, it's actually a minority of patients who have that. What we know is that epilepsy has a predilection for this CA1 region and the dentate gyrus, which makes up this hilum. And so we see a majority of these patients with temporal lobe epilepsy actually only have damage to these subfields. And when you look at the accuracy of measuring whole hippocampal volumes combined with normal asymmetries and variability from side to side, when you look at whole hippocampal volumetrics and predicting lateralization in temporal lobe epilepsy, it doesn't perform great. It still does not beat a skilled reader. And I think the reason largely is because the skilled reader can pick up on these morphologic changes. So like in this case, we see from side to side, the hippocampus overall looks pretty symmetric in size. But if you look closely, you can see on the left here that we have atrophy in the CA1 region. You can see how it's kind of flat versus this normal tapering appearance of the CA1 and subiculum. And so this has to be considered an MRI positive case. This is, there's no question about it. So I think this is why 7T really excels in evaluating the hippocampus, is that we better assess this architecture because we get less volume averaging effect with thinner slices. So here is just some data to support that. So this obscuration of this internal architecture, it's been commonly described in the literature as a marker of hippocampal sclerosis. And there's no doubt that we do occasionally see patients who may have like autoimmune epilepsy or have had a recent seizure that have edema. The hippocampus is usually like larger, and you see, it's brighter. It's this internal anatomy is obscured. So that does happen. But in patients who have just kind of normal hippocampal volumes and you don't see this anatomy well, I've always thought that this is mostly an artifact of imaging, and I think 7T supports that because what we see is if you're scoring these on the conspicuity of the internal architecture. What you can see is that even in the normal hippocampus, that at 3T, the average score is kind of in the middle, whereas at 7T, it's, the score is much higher. And this was using 2 mm slice thickness, which is pretty generous for 7T. I would say, in our experience using 1 mm slices, that you see this anatomy in almost every case other than those kind of end-stage MTS cases. So this just shows the added value. So what we often see, though, is the opposite effect. So this was a patient where the left hippocampus was thought to be potentially abnormal on this outside scan, but the patient did not have temporal lobe epilepsy. So you can see when we repeated the 7T that it's actually normal. And then another case here where you see on the left, the hippocampus looks kind of odd, but on the 7T it's normal. So again, just kind of showing that volume averaging artifact that can lead to misdiagnoses. So the next thing I'll talk about is cerebrovascular disease. And I think this is one of the relatively unexplored applications of clinical 7T, but there are a lot of advantages to certain aspects of vascular imaging. I think there have been some technical hurdles that have limited adoption. And so things like ASL should be highly advantageous at 7T, but there are challenges with like the labeling, for instance, because of the B1. But there's been a lot of progress on this. So just some of the things that we do routinely use now, though, are like time of flight imaging. So time of flight, because of the longer labeling, we see vessels further out. And because of the added SNR, we can see much smaller vessels. So here's just a patient comparing 7T to 3T. This was a case we had of this patient who was sent to us with these bilateral thalamic lesions. And we had suspected that this was vascular and etiology. And they had this outside CT angiogram, which looked pretty normal. But what we see here on the 7T, as you can see this occluded vessel here, this is an artery of Percheron. So this is a vascular variant where there's kind of a single vessel that supplies the perforator vessels to both thalami. And so this is a fairly typical pattern of artery Percheron infarct, but you don't see this even in just like a catheter angiogram. So this really allowed us to make a confident diagnosis. So again, just showing the differences between 7T and 3T. 7T is also better at characterizing aneurysms. And so we do this in a lot of our aneurysm patients. This is just an example of one that we published where this patient, we knew they had this aneurysm on 3T. When we repeated the 7T, you can better see the origin of this small parent vessel coming off. And then you can see the added complexity of the aneurysm. This actually swayed our neurosurgeons into actually treating this patient because the complexity of the aneurysm was much worse than they had initially thought. And one study that looked at small aneurysms that had been incidentally discovered on 3T, they found that 2/3 were not aneurysms. They were vascular variants, again, fundibulum and stuff like that. So this may spare a lot of patients from having unnecessary angiograms, unnecessary follow-up. And so this is a very promising area for cerebrovascular disease. We can also do these MRA and MRV post-contrast. So again, leveraging the added spatial resolution of 7T. And then you will move into talking about these susceptibility or T2 star weighted images. These are a common diagnostic tool in neuroradiology, and we can see here this case of a young woman who presented with these new onset finger symptoms that they were suspected to be focal motor aware seizures. And so she had this 3T scan done. There was this small little lesion here that nobody really knew exactly what it was from. And then when we did the 7T, you can see this developmental venous anomaly associated with this lesion, which is very typical of a cavernous malformation. And so again, just adding to the certainty of the diagnosis in this patient. These were a series of patients that one of our vascular neurologists had in clinic that came in with very typical symptoms of TIA. They resolved within a couple of hours. They had an MRI, which was normal, and then followed up with him. And so he was like, can I scan these patients on the 7T? And I was like, sure, why not? And let's see. And we did not expect to find this, but we found in all of these patients that they had these intracortical microhemorrhages that were really isolated only to the area that corresponded to their clinical deficits, and we couldn't see them on their prior imaging. And so this suggests that some of these patients actually do have abnormalities that are just not detected, even though these symptoms are transient in nature. The question is, what does it mean? And we don't know. That would require a lot of population studies. We know that patients who have TIAs, who have microhemorrhages from other reasons, are much higher risk of having a major intracerebral hemorrhage or stroke. So these may also portend a worse prognosis. Just as a reminder, we talked about fMRI. Again, this is something that's been well studied at 7T. So we do a lot of our clinical fMRI cases for pre-surgical planning, for epilepsy evaluations, DBS planning, and so the advantages are pretty obvious to 7T. But and here's just showing an example of just a language activation here, and you can see very nicely the separation of these different language areas from like the traditional Broca's area to the ventral premotor cortex, which is an area we commonly don't resolve on these same paradigms on 3T, just with the lower bold sensitivity. So you get really nice activation maps. But I want to present in the context of this as something that I think is maybe more interesting from the cerebrovascular standpoint is cerebrovascular reactivity mapping, which is kind of akin to like a stress test for the brain. We give some type of stimulus to cause vasodilation and look at how the brain responds to that. And commonly this in the past was done with Diamox or acetazolamide, which is a pharmaceutical vasodilator. And but these patients, the reason we stopped using this is we had a patient who actually had a stroke when they were on the scanner when given Diamox. So our neurosurgeons were like, we're not going to do this anymore. So in response to that, we switched to using bold MRI with CO2, which I know is something that a lot of this development was done here. And there's several ways of doing this. You can have the patients hold their breath. This is difficult because patients have a lot of other comorbidities. They may or may not be able to hold their breath well. We actually did one of these patients under general anesthesia, where you have great control over their respirations and also PCO2 monitoring. And we found paralyzing them for like a minute, their PCO2 does not change as much as you would think. It's very, very small. So after that, our experience with using these breath holding was always pretty variable, didn't always really correlate with what we saw clinically. So we were looking for another method. And so you can use other ways of delivering CO2 gas. The way that we do it is using this Respirax system. And this is kind of a rebreather system that actually administers CO2, oxygen, mixed gases. And it also monitors the PCO2, so we can actually get very precise control over their PCO2 and these rapid changes. So within a breath or two, we can have massive changes in their PCO2. These patients, when they hit this step part where their PCO2 goes up like this, they often just get short of breath. It's a very profound change in CO2. And so this is valuable because it gives us very precise control and allows us to have more reproducibility from time to time. We're not dependent on the patient, on their breathing patterns and things like that. They're forcibly given this PCO2 change that's prescribed to them. It allows us to also do it and kind of deliver it in different paradigms. So we can do this very rapid change, and we can actually measure how their brain, how quickly it responds. So we call this a tau measure. So we often see that the rapidness of the response often diminishes early when they still have a maintained CVR. So we assess that by using this ramp phase where we drop their PCO2 really low and then slowly ramp them up. And this gives you a good measure of kind of their max CVR. And we often find these don't always correlate. So we see like in our Moya patients that often this tau is impaired, so their response to the stimulus is slow, but it catches up. And so we're not entirely sure what that means yet, but it's very profound effect that we often see in these patients. So obviously, we were interested in 7T for this because of the added bold SNR. And so here's just a normal subject showing a max CVR. This was a patient who had Moya. You can see they have this chronic left ICA occlusion. And we had been following this patient for a while using these breath hold sequences that looked normal. And but this patient, he was clinically symptomatic. So he was one that we sent to try the 7T on. And you can see that indeed he has this CVR impairment in these watershed regions and this kind of still phenomenon. And comparing this, his scan on the 3T versus 7T, we can see that the measured decrease in their cerebrovascular reactivity is much greater at 7T. And so there may be a number of reasons this is true. One is not only the added bold SNR at 7T, but also one of the contaminants of this is the volume averaging between the cortex that we're interested in with white matter and then CSF with very drastically different bold responses. So by increasing the spatial resolution, you can decrease that volume averaging effect, and I think you measure a much more detectable signal change. Here's comparing his images from 3T and 7T, and so again, at 3T is much more difficult to appreciate these areas where the CVR is decreased. But one of the other things that we're interested in exploring is using spin echo EPI sequences. So traditionally, we use gradient EPI sequences for bold imaging because the higher sensitivity to the bold response. But it's important to remember that the GRE bold response has up to 50% of the signal comes from cortical macrovascular sources like large draining veins. So this is a pretty profound effect. And that goes back to the image that I was showing earlier on, where you see that the layers that are closer to the peel surface, you get contamination of these vessels in the normal signal. So with spin echo bold, you have the refocusing of the static dephasing around these large vessels. And then we also see ultra high field that the signal contribution from the large vessels is diminished because of the shorter T2 of the venous blood. So essentially, this shifts the measured signal more towards small vessels of interest when we use spin echo sequences. But the problem is that spin echo is much lower SNR than gradient sequences. So this is why it's very difficult to do this at lower field strengths. It also has a much higher SAR, so it limits your ability to image, large volumes and high resolution as you can with GRE sequences. And so here's why we think this is helpful. If you look at this patient, or this is actually one of my colleagues, a normal volunteer here. So we can see on the GRE sequence how much signal is around these large veins. So you see, in the sylvian fissure, these large arteries around these dural sinuses. When you compare that to the spin echo, you can see that the bleeding of that signal into the cortex is much, much lower when you use spin echo. And if you look at the voxels here that contribute most to the mean signal with the gradient, you can see these all cluster around these deep cerebral veins, venous sinuses, these large vessels in the sylvian fissure, and it's much more evenly distributed with the spin echo sequence. So, we're very interested in using this approach for CVR. The next thing that I'll mention is Parkinson's disease, and this has been a very useful tool for us. We have a large Parkinson's clinic, and again, this is one of those things that some of these patients can be very hard to diagnose early on. There are a lot of movement disorders that can have similar features as Parkinson's. And so, oftentimes these patients they're diagnosed because of their response to medication, which is not a great biomarker. And so we were interested in the potential advantages of 7T for making this diagnosis. And just as a reminder, the substantia nigra is one of the key parts of Parkinson's disease. We have a pars compacta, which is the more medial portion that is rich in dopaminergic cells, and neuromelanin is a byproduct of the dopamine synthesis. And it normally has a low iron content compared to the pars reticulata, which is the more lateral GABAergic portion. And so the loss of these dopaminergic cells in the pars compacta is the hallmark of Parkinson's. And so there are various ways that we can measure these things. So we can use like T2 star, SWI sequences, QSM to look at iron deposition patterns. We can measure neuromelanin. And so here's just an example of one of the things that has been commonly described is the loss of this hyperintense signal here within the dorsal substantia nigra. And this is often referred to as this nigrosome 1 region. It turns out this is actually only like a small portion of the nigrosome 1, but this hyperintensity this is what it looks like normally. And what happens is as you have the pathologic iron deposition from degeneration of these cells in the pars compacta, the increased iron deposition lowers the signal here, and this kind of bright area goes away. And so if you look in the literature, this is like a great sign to use, the so-called swallowtail sign. If you ask any neuroradiologist, they will complain endlessly about how reliable this actually is. So in practice, it doesn't work quite as well at 3T as the literature might suggest. So 7T, we actually see this much more confidently compared to lower field strengths. And so here's just an example where we see normal and then this increased iron deposition in the Parkinson's patient. One of the things that we're more excited about, though, is using MR to quantify neuromelanin. And so again, this is a byproduct of the dopamine synthesis. And here you can see the normal locus ceruleus and the pars compacta, which are both affected by Parkinson's disease. And so this neuromelanin imaging is, it can be challenging at 3T because we have limited SNR. So this generally requires using higher slice thickness, which is problematic because this is a small structure. The contrast is lower, scans are often much longer. And so we can leverage the advantages of 7T for this. And we can also acquire this multi-echo data and do kind of simultaneous mapping of R2 star and QSM. So here, again, just showing the normal neuromelanin within a control patient compared to this Parkinson's patient where you see the diminished neuromelanin signal. And so in our preliminary analysis of this, we found that the sensitivity and specificity were 100% differentiating PD from controls and ET. And so this is also potentially one of the earliest markers of Parkinson's disease. So we're hopeful that this can be a good biomarker for patients who have hereditary predispositions to Parkinson's and things like that. And it may eliminate the need of additional costly exams like SPECT or 18F-DOPA PET. Here's an example patient. This is a good patient example because it really illustrates kind of the normal and abnormal processes here. We know that Parkinson's is, in a lot of patients, has a very asymmetric presentation. This patient had nearly all right-sided symptoms. And so you can see on the neuromelanin, the neuromelanin is low, but particularly lower on the left side. And then you see the increased iron deposition where we lose that bright spot here. We see the R2 star and T2 star also reflecting that high iron deposition within the pars compacta. And so here's just another example where these tools can be helpful. This was an elderly man who presented with these worsening cerebellar symptoms, and he prompted him to have this genetic workup that uncovered this kind of borderline repeats in his spinocerebellar ataxia 8 gene. And so he was given this diagnosis and was sent to us for further evaluation. And so the first thing that happened when he got to our clinic was he got this 7T scan. And you can see between this outside MR 6 years prior, this kind of progressive atrophy of the cerebellum, of the brainstem. He has this kind of degeneration in these crossing pontocerebellar fibers and raphe nuclei, this kind of hot cross bun sign, if you will, all very typical imaging features of spinocerebellar ataxia. But he also had this. So he has a ton of iron deposition in his substantia nigra and red nucleus. His neuromelanin is depleted on both sides. And so I called our neurologist and said, this guy is very bizarre. Like I looked through the path literature. I could not find anything about the substantia nigra being affected in these spinocerebellar ataxia patients. And so I talked to him about it. And then he saw the patient and was like, oh yeah, they have this upward gaze palsy. He's had worsening of his gait. He has this rigidity, spasticity, tremor. We ended up doing an ioflupine SPECT scan, which was abnormal. So this patient actually has a combined diagnosis of spinocerebellar ataxia and progressive supranuclear palsy. And so it turns out that this is a very rare association between these two very uncommon disorders that really reflect this same patient's demographic. They're usually elderly. They usually have a low number of repeats. So their SCA8 is more mild. So it's probably they live longer to manifest this. But this was one of only I think 3 patients that have ever been reported. So the last things I'll finish up with is neuromodulation. And so the 7T has become kind of our standard for assessing patients prior to neuromodulation. And the way that we do this historically has kind of evolved under 2 routes. One is direct targeting, so seeing these structures we're looking at, like the subthalamic nucleus and so on. But there's new evolution towards this idea of connectome surgery, so targeting brain networks. So I'll show you where 7T kind of fits into both of these. So traditionally with DBS, we used atlas-based stereotaxy, so like the ACPC line, and would measure, distance from the ACPC line. It's a very crude way of doing this. And then in the OR, they would have microelectrode recordings and things like that to kind of refine their placement. And then that kind of evolved to using these deformable atlases, but neither really accounts for variations in patient-specific anatomy or, more important, functional anatomy. So with advances in MRI, though, it really allowed us to much better see these structures of interest. And ultimately, what we've seen is a decline in these microelectrode recordings, which is great for the patient, and then also the ability to do these asleep. So historically, these are all done as awake surgeries, and so now this opens up DBS to a lot more potential patients. And so the reason this is important is, I think, illustrated well here. If we look at patients with temporal lobe epilepsy who are undergoing DBS of the anterior nucleus, what we know is that these patients with temporal lobe epilepsy have thalamic atrophy, very specific morphologic changes involving the anterior and medial portions of the thalamus. And you can see that reflected in the difference between direct and indirect targeting. The difference in the coordinates varies quite a bit by their thalamic volume. So this atrophy greatly affects this indirect targeting approach. We also have data from the movement disorder side. So this was a study looking at direct targeting versus indirect targeting for STN and GPI DBS. And they actually found that with the direct targeting, these patients had improved outcomes versus the indirect targeting. They had better motor outcomes at 12 months and greater reduction in their levodopa usage. We also see that translate to the asleep, the IMRI guided, so using direct visualization under general anesthesia for STN DBS. If you had proposed this like 25 years ago, you would have probably lost your license. Now it's not that uncommon to do this. And so they actually found that compared to doing the traditional awake surgery, that using IMRI, they actually had a lower error rate for both of these targets. They had fewer lead passes, and then ultimately the outcomes were not significantly different. So this just shows that this is all feasible, all advances made strictly by MR, improvements in MR technology. So with the STN, the direct targeting is often done using sequences that leverage the normal iron concentration within the STN. And so here's just showing an example of using a T2 sequence. You can see from 1.5 to 3 to 7T, the improved SNR. And in particular, where surgeons generally struggle is along the bottom border of the STN because it starts to blend with the substantia nigra. So you can see here at lower field strengths, you can see the top, you can see the edges, but you really can't see the bottom. And we see this when they use microelectrode recordings, validating the imaging data is where they are most inaccurate is on the ventral border. And so 7T, you can see much better defines the boundary between these structures. So, so that's a huge advantage. We also use this in our tremor cases. So this is F-Gator sequence, which is a white matter nulled MP-RAGE. And so we can actually see these tracks here are the cerebellothalamocortical tracks are what we are targeting. And we can actually see these on the structural imaging. So we don't need to do the tractography, makes these much simpler. So what we do is you can see that in the sagittal plane here as we place the electrode tip across these fibers. And this works extremely well. Since we've been doing this, we haven't had to reposition any of these leads. So this works extremely well. We also, this edge sequence again that I mentioned earlier is a way that we came up with targeting the centromedian nucleus, which is a target for Tourette's and now increasing interest in epilepsy. And you can see compared to 3T that we can do this with higher resolution, much shorter time with much better SNR. Here again is the T2 space. So one of the sequences that we use with targeting the STN. And so you can see the STN borders extremely well using this sequence. This is a multi-echo SWI. So again, here I was looking at the GPI. We can see the GPI and GPE distinguished really easily here. So we generally target this along the border between the GPI and GPE posteriorly. And then here's that sequence that we use. It's 0.5 isotropic multi-echo SWI, and we also can generate the QSM from this data as well. So the last thing I want to mention is this idea of connectome surgery. And so this has been really a shift away in DBS from the structural targeting to looking more at network-based targeting. And it turns out that a lot of the effects of neuromodulation are not well explained just using a purely structural model. And so we have found that this approach much better explains both the therapeutic and the off-target effects of DBS. And this is also important because what's been, I think, neglected for decades in the DBS world is we also often talk about stimulating these nuclei, but mostly we use high frequency stimulation in DBS. And we know that the effects on cell bodies is much lower than on axons at high frequencies. So it's likely that the tracks actually mediate a lot of the effects of DBS. So this is one area where I think 7T may be potentially advantageous. So just as some background, this was looking at patients being treated for tremor, which historically we targeted this ventral intermediate nucleus of the thalamus. But it turns out that there's a lot of debate in the literature about where to target these patients. And so we did this where we looked at the tracks from all stimulations mapped to the clinical improvement to see what tracks actually correlated best with tremor improvement. And it's this track that I mentioned earlier, this dentator rubothalamic tract. And so we can actually use that fingerprint, this connectome fingerprint, to predict outcomes in cohorts from other hospitals. And then we actually did this as a blinded sham trial where we used the standard of care programming at 3 months versus a track-based stimulation model versus a sham. And you can see that almost every patient did better with just one image-guided stimulation setting. This also, we found this applies to non-invasive approaches like SRS. And so again, using these connectome fingerprints to predict patient outcomes. We see the same thing in dystonia. This was one of my postdocs published this looking at the mediators for dystonia. This is important because in dystonia, we don't have a great clinical biomarker. The response is not immediate like we see with tremor. So this may, these patients often take up to a year to optimize their programming. So the idea if we can do it at their first setting is a pretty big deal. We also see this like with Parkinson's. So again, using these connectome fingerprints, we can get pretty close predictions of their outcomes. And this has also been shown in OCD. So again, using these connectivity models to better predict outcomes and consolidate a lot of the previous targets in the literature. And then also we see with epilepsy, with anterior nucleus stimulation, that again, we can use these fingerprints to look at their outcomes. And so where does 7T come in? So most of these targets, again, they're all these deep central targets. And while the cortical SNR at 3T and with phased array coils is not bad, when you start looking at these subcortical structures where you're further from the head coil, more physiologic noise, we see that the TSNR at 7T in these subcortical regions shown the optimized one here in green versus 3T. And for the purple here, you can see dramatically increased TSNR at 7T. So but all of this is not positive though. So a lot of these tracks that we're talking about are these subcortical basal ganglia circuits, and they're very difficult to identify by tractography. They often have unusual like curved geometries. A lot of these like cross across the internal capsule, makes it very difficult to track them. They're also all very deep in the brain, so the lowest SNR area. So I think this 7T is actually has some problems with tractography because of the T2 star decay is so fast. It's very hard to do these kind of high B value images at 7T. There's the gradient systems keep improving, which may make this a little more feasible. But the tractography is something that's not entirely advantageous at 7T. But when we think about these targets in particular, there are some unique advantages like the higher SNR and then being able to see very small structures. So the ability to image these very small tracks makes it very difficult at 3T, even with like these connectome scanners and things like that. So this is just some examples using the super resolution and track density imaging at 7T. So we see a lot of these subcortical pathways that connecting these structures like the ancilla lenticularis and things that we know mediate a lot of these effects of DBS. And then this is looking at 7T data using the network connections from these tracks from the subthalamic nucleus to kind of segment out these functional regions. So as opposed to the thalamus where we have these kind of histologic differences within the thalamus, the targets like STN, GPI, they have this functional gradient within them, but they don't really have histologic differences that can be detected. So by structural MR, they look very homogeneous, but the functional connectivity is very different. So the idea here is that we can depict those functional zones by segmenting it based on its connections. And so it probably exists something more like this, kind of along this functional gradient where we have more sensory motor areas and kind of this posterior lateral area and associative and limbic regions. And so I won't go into the details of this, but this model actually explains a lot of the effects we see from DBS from not only Parkinson's, but also things like OCD and Tourette's. So it's a really strong model. And we can see here, looking at Parkinson's patients, that using these segmentations, the active contact that was used in these patients all lies kind of within this sensory motor area, kind of bordering on this associative region. And here's a patient where they had this minimal motor improvement and after DBS and had severe mood disturbances. And you can see the original lead on this side is way anterior towards this limbic and associative region. And so it was repositioned more posteriorly into the sensory motor area, and they had resolution of these mood effects and improved motor symptoms. So that leads me to kind of the last thing here is I think that the future of DBS is really predicated upon the symptom-specific mapping and mapping those to specific networks and using that information to guide programming. I think that although feasibility and cost and things like that may limit every DBS patient from getting programmed based on imaging, I think that patients who have certain conditions or are troublesome to optimize, this will be the tool that we will use in the future to optimize them, is using fMRI and tractography to map for any individual patient what gives kind of this network fingerprint from their stimulation. And so this just shows this illustrated for Parkinson's, where we often talk about kind of a sweet spot for Parkinson's, but the reality is these patients are phenotypically very different. And if you use something like a UPDRS score, encompasses all their symptoms. So two people that have the same UPDRS score may look entirely different. So how do we better assess these patients? Well, we know that these symptoms all map to different networks. And so by taking any individual phenotype, we can take that person and optimize DBS for their specific symptoms. And so I think this will be ultimately where 7T may be advantageous. What's interesting is because we usually use like the extensions are a 30-centimeter wire for DBS, is actually potentially safer at 7T to image these patients with a DBS in place than it is with 3T. Obviously, there's no regulatory data on that, but there are studies looking at this, the feasibility of doing this. So just to kind of conclude, with optimization, I think 7T already can be used routinely in clinical imaging. In our site, we do about 4 to 6 cases a day, about 1,200 clinical cases a year. 7T clearly has advantages in certain conditions. It's probably not universally better than 3T at this certain stage, but there are certainly patients where it is highly advantageous. And then I think that, just like with 3T and everything else, is that this will get better, technology will evolve, and it will be, I think, much more generalizable. And I think our experience that we've already seen substantial impacts on our patients' care. So this is my team. And so they, I think, really are the ones responsible for most of this work. I have a great team of physicists. Our lead technologist, when she is on vacation, we fill it. It's a very finicky system. So that's another big consideration when using the 7T is having the right tech expertise. And so I will end there if anyone has any questions.
Well, thank you so much, Erica. This is a wonderful talk. So we have questions coming in the QA. There's a sort of an urgent question because Hanzang needs to leave in a few minutes. So I read that first. So Erica, I have to leave in a couple of minutes, but I'm curious, what's your experience with perfusion MRI at 7T for both contrast-based and non-contrast ASL methods?
We have not done contrast. The FDA clearance actually doesn't cover contrast at 7T. So I have to say that the contrast stuff that I've shown is off-label. And so I don't have any experience with that. ASL has proven difficult, and it's mostly due to the labeling. So it's much harder to image kind of lower areas. We've gotten to the point, if you're looking from like cerebellum up, it works pretty well. But I've seen Danny Wang at USC. I think they just recently published a lot of the work they've been doing over the past few years. I'm going to see Danny in like 2 days. So I'm going to try to steal all of his work from him. But I think they've made a lot of progress. So we developed this. We've used it in a few patients, just moved them over to the 7T to just try to see how well it worked. And so it's not really to the point yet that we're that comfortable using it routinely, but that may just be our experience. I think it'll be interesting to see what Danny and his team have come up with.
Okay, great. Thank you. Yeah, talking about the ASL, I think Danny has been doing some good sequences in terms of readout. I thought, what you mentioned, the labeling is really the problem, right? Bottom of the brain. I was wondering, is there a difference sort of when you do it on the FDA-approved scanner and the other more research, developed scanner? Is there a difference in terms of that?
So I actually can't recall if I want to say there's not an ASL product sequence on the Siemens platform. So what we have been using though is Danny's stuff. He didn't share his most up-to-date stuff with us yet. I guess it wasn't published yet, but he's been helping us a lot with what we've set up. And so we have used for the PCASL, we've had a little bit more difficult time also with the 3D. And so, but I think from his work that they've had a little more luck in recent, with some of their recent innovations. So, but yeah, it's mostly kind of a labeling issue. And I think the head coil geometry doesn't help us either. I don't know if having separate like labeling coils and things like, I guess going backwards in time may prove useful, but yeah, we don't have a lot of experience with actually using it in patients.
Yeah, great, thank you.